everybody. This is iCubed episode 47. Yeah, just one more and it's 4 years. 4 years of my labor and love. Well, I am thrilled to have this guest today. I consider him the 5th member of the Baywood Maricopa Medical Center Residency cohort, Dr. Paul Domer. Yay! Welcome, Paul.
Thank you. Happy to be here.
Well, Paul is our medical director in the ER right now, and I am ecstatic that he's been leading us this whole year through this awful year, but he's been doing such a great job. Now, Paul, please introduce yourself, where did you go to school and all that?
Sure. I went to my undergrad in biochemistry at BYU in Utah, and I did medical school at Midwestern University in Glendale, Arizona. And it worked out well. I was able to attend residency in emergency medicine at Maricopa Medical Center here in Phoenix, as you mentioned, and then worked here for a short time afterwards, spent some time in Utah, and then recently relocated back to Arizona.
Well, Paul, I have told you so many times, I'm so grateful that you are our leader. You've been such a terrific leader for us through this really rough year. And I really appreciate your humility, your leadership of our group very much. All right. So Paul, you know how things are. You've been here for a year. We get very sick patients all the time. This one, no different. 75-year-old male, he was brought in by EMS with complaint of vomiting blood and passing black stools and hypotensive. This all began earlier that day.
Okay.
He has a history of metastatic bladder cancer. He has a history of hypertension and atrial fib on Eliquis. Has no history of liver disease. So EMS vitals, we're told, blood pressure was 85/43, heart rate of 112, respirations of 16, Glasgow Coma Scale was 15. And this is the vitals we have in the room. Blood pressure of 74/54, heart rate is 143, respirations of 21, temps 97.5, and sat is 95%. What do you think?
This gentleman is in big trouble.
Yeah. So I walk into the room, and just in general, he's pale. He's awake, talking. He is thin. His daughter's at the bedside. I talk with him, and he's like, I just feel really weak and dizzy. I've got some abdominal pain. Okay. So then I'm standing next to him on his left side, and then all of a sudden, he gets nauseous. He turns to his right, and he vomits, like twice, giant volumes of dark blood out the side of the bed. The daughter's like at the foot of the bed, right? I'm like, oh. So now what, Paul?
You know, this is one of those situations where I get really nervous. This is even though he's awake and talking, this is an impending arrest, and so I tend to be fairly aggressive on these patients, and really just getting the ABCs covered, and usually intubating these patients and getting really good IV access, and just starting getting emergency release blood going ASAP. Also getting your consultants ducks in a row, an intensivist, a gastroenterologist, and also just in the back of my mind, making sure there's not more to the case. You know, does he have a AAA? Does he have a graft? Is there something worse going on before, while he can still talk to me, and just making sure there's not something else that's complicating the case.
Right. So, like, when you walk into a very sick patient's room, you start, if you can talk to them, you start to get some history. And then if they do something like this, it accelerates your action, right? Your action plan. And ABCs, always ABCs, right? And we can't emphasize that enough. So I'm really glad you talked about that, thinking right away about airway, breathing, circulation, right? So I'll tell you what I did immediately. I ordered O positive blood because he's a man. I ordered PCC because he's on Eliquis, and then I ordered TXA because TXA is the, right, the uni drug.
Yeah.
I'm going to leave the patient scenario right there because this leads it to my learning focus number 1. So my learning focus number 1 is TXA in GI bleeds. Now, I have been a fan of TXA for a long time, and so has the majority of emergency physicians. We've used it in everything, kind of like magnesium, right? You use it in everything. Well, actually, let me talk about this trial because it's really, really well done, and the educators that I look up to have talked about this trial and how good it is, and so I want to go through it using this case. But before we launch into the study, I just want to do a little review. Roughly 2 or 3 years ago, when I started this endeavor, I had a case that I talked to Bill Fulton about. It was a uncontrolled bleeding after dental procedure on a patient who was on a NOAC. So here we go, fibrinolysis chart for dummies. Fibrin is assumed is the clot, right? So you make a clot, and then plasminogen and plasmin make FDP, or fibrin degradation products, because they cut that, clot down into little pieces, essentially. Yeah. So where does tranexamic acid work? Well, tranexamic acid works right there. It stops the plasminogen and plasmin from working. So what it does is keeps the clot from dissolving. Okay. So if you're bleeding, your body naturally would form clots, right? So when you put the tranexamic acid IV or topically, what it's doing is keeping your body from breaking down its clots.
Okay. All right. There
you go.
Nice. I like it. Simple concept.
For dummies. Yeah, exactly. Yeah. All right. So the Halted trial was posted in Lancet, Volume 395 in June of this year, June 2020. Rebel EM with Salim Rezai had a great podcast about this, so I would recommend you listen to it. So the clinical question for this study was, does IV TXA reduce 5-day death due to bleeding in adults with acute GI bleeding compared with a placebo? The TXA treatment was 1 gram in 100 cc's of saline over 10 minutes, and then 3 grams over 24 hours. The placebo treatment was matching normal saline. The inclusion criteria were adults that were either greater than 16 or 18, because it depended on which country they studied it in. Some countries define adults as 16, and some countries define adults as 18. The patients had to have significant upper GI or lower GI bleed, which meant hypotension, tachycardia, signs of shock, likely to need transfusion, surgery, or endoscopy. It was an international, multi-centered, randomized placebo-controlled trial in 164 hospitals, 15 countries. It was conducted between July 4th of 2013 to June 21, 2019, so basically 6 years. And 12,009 patients were enrolled. 5,994 received TXA, and 6,015 received placebo. So what were the results? That's kind of the bottom line, I guess, right? What were the Halted trial results? Well, these are the conclusions of the other 2 websites that I used for this episode. But I thought that we should probably go through it a little bit so we can understand the results, okay? So like I said earlier, 12,000 basically enrolled, and half were given the TXA and half given the placebo. 89% of these patients had upper GI bleeds. 55% had suspected variceal bleeds. Then 9%, only 9% were on anticoagulation. 41% had liver disease. Yeah. So the primary outcome was 5-day mortality due to bleeding. In the TXA group, 222 patients, or 4%. In the placebo group, 226 patients, or 4%. The arterial thromboembolic events, TXA group had 42 patients, which is 0.7%. In the placebo group, 46 patients, which is 0.8%. In terms of DVT or PEs, the TXA group had 48 patients, which is 0.8%, and the placebo group had 26 patients, which is 0.4%, and the number needed to harm was 250. In terms of seizures, in the TXA group, 38 patients, 0.6%, in the placebo group, 22 patients, or 0.4%. The proportion of patients who had surgery, radiologic intervention, and blood transfusions were similar in both groups. So the author of this HALT-IT trial concluded that there was no benefit of giving TXA on 5-day mortality, and there's a small signal of harm with increased VTE and seizures. Now, I went through this article pretty thoroughly, and there's a few points I really want us to remember and keep in mind. We have to remember that the majority of these patients had GI bleed from variceal bleeding. So 55% of these patients had GI bleeding from variceal bleeds. The 75% of the deaths were actually from variceal bleeds. And only 9% of participants were on anticoagulants. That's so different from our patient population. And unlike trauma or postpartum hemorrhage, which is where some major studies were done in terms of TXA's effectiveness in reducing bleeding and death, unlike trauma or postpartum hemorrhage, the exact time of onset of a GI bleed is really hard to establish. The time of onset of randomization in less than 3 hours was only 16% of the patient. I mean, that just supports that idea that you really don't know exactly when your GI bleed started versus in trauma where, you get the femur fracture, you're bleeding at that moment, right? But still, there's no statistical difference between those with time of onset of less than 3 hours or greater than 3 hours of the GI bleed. Any thoughts?
Yeah, I think it just speaks to their just sort of different patient populations. These trauma patients, postpartum hemorrhage patients are generally younger and generally probably more healthy patients with good blood clotting systems at baseline, rather than these liver patients who are coagulopathic just from the liver disease, and then maybe they also have an anticoagulant, although it sounds like that was low.
Yeah.
I suspect that they'd have to do some more investigation on subpopulations to see subpopulations of the GI bleeds to see if there's to see the benefit. There probably is some benefit in some patients, much like the trauma and postpartum hemorrhage. It doesn't look to me like there's really a ton of evidence that it harms. Like they said, there's that kind of maybe a little bit of a signal there.
Yeah, it's a tiny bit of a possible harm. Yeah, I mean, I think that if you recall, I did order TXA right off the bat, as well as the other things for this critical emergent sort of peri-arrest patient, right? But after going through this, I think that in the set of patients that this study included, I think that evidence is that TXA is not effective, not useful. So being aware of the characteristics of the patient population in this study, for me, will help me sort of personalize treatment. And in this set of patients, I will not be using TXA and then upper GI bleed for sure, because it's very convincing, the findings of this this study. So when I was thinking about this, I was like, well, if TXA doesn't work, what do I do? How do I take care of a patient who's on an anticoagulant, who's bleeding and peri-arrest, right? And that leads me to my second learning focus. Anticoagulation reversal. Now, this is kind of a complicated thing, but let's talk about it a little bit. This article is just a recent article in the Western Journal of Emergency Medicine, September 2019. It's a really terrific article, but it's pretty dense. It was by Dr. Yee and Dr. Kaidi in Wexner Medical Center, Ohio State University, Department of Emergency Medicine in Columbus, Ohio.
That's pronounced the Ohio State University, by the way.
Wait, what connection do you have with the Ohio State University?
Oh, just a big college football fan. You don't want to say Ohio State. You got to say the Ohio State University.
I stand corrected. All right. So that article, like I said, really a terrific article, right? Very dense. It has all these terrific charts to lead you through. But when I see all those charts, I just want to cry, right? So my advice is this. Yeah. Use your EMR care sets for anticoagulation reversal, okay? But I feel compelled to at least teach sort of in a relatively simple manner anticoagulation reversal to help you make a decision. So let's go through this relatively quickly. These are the conventional oral and parenteral anticoagulants that, you and I, we've kind of grown up using this, right? Warfarin, heparin, Lovenox, Rixtra. These are your typical old-fashioned conventional oral anticoagulants. Then about, 10 years ago maybe, these DOACs or NOACs, direct oral anticoagulants, or new oral anticoagulants came on the scene, right? So we've got the Pradaxa, we've got the Eliquis, we've got the Xarelto, and the Savesa, and the Bevixa. So I'm going to give you a little pearl. All of these generic names that have X's in them, all of those are 10A factor inhibitors. So anticoagulant reversal in the ED, commit to memory these next 3 slides. That's why the elephant, okay. Number 1, Praxpine, which is idarucizumab, is for the reversal of Pradaxa only. Number 2, protamine sulfate is for the reversal of heparin and enoxaparin. So protamine sulfate for heparins, basically. Slide number 3, 4-factor PCC or activated PCC or andexanet are for the rest, okay? Now what do I mean? The rest just means warfarin, your NOACs, and your Rixtra. That's all you need to remember, okay, Paul? You got it?
Yeah.
I just wanted for us to have a general sort of conceptual idea of how we go about reversing an anticoagulant that's life-threatening. I mean, a GI bleed, or not even just a GI bleed, but somebody who's having intracranial hemorrhage, a large hematoma bleeding, arterial bleed into a closed compartment, and anything where, it could really compromise a person's life or limb or brain, right? So I think that if we know this, just even at least for me, even if I just know generally the concept, it helps me make quicker decisions on which direction to go. And that's why when this happened with this gentleman, I immediately I knew he was at Eliquis. Whether he took it that day or not, I did not know, okay? But I knew he was like peri-arrest. He needed help, immediately stabilization, and he needed his Eliquis reverse. And he And to me, and he needed blood. Like you said, I'm very aggressive with resuscitation, either airway or with the vitals. So I immediately, when he vomited that blood, I was immediately like, okay, he needs blood right now. We need to, even if his blood count comes back, fine, he needs blood right now. So I ordered the blood, O positive because he's a male, and the PCC and TXA right away. And then I just wanted to go through this a little bit because there is some financial disparities in the cost of these treatments, and I think that we need to be just aware of it, even though money isn't always the most important thing, I guess, or cost isn't the most important thing, but I just want us to be aware of the difference. So 4-factor PCC, roughly for 80 kilogram patient, is about $2,000 to $5,000. It looks like activated PCC is 5,000-ish. Idarosuzumab, which is Praxpine, is roughly 3,600. And then the Andexanet is $24,000 for the low dose.
Wow.
And Andexanet for the high dose is almost $50,000 to treat an 80 kilogram patient. We don't have it on our formulary. All right, so I know you guys are just dying to hear what happened to the patient, right? All right, so his labs came back. Hemoglobin was 7.9, and that's not accurate. His bleeding had just started before he came in, and then he puked a huge amount of blood. And when they put an NG tube in, he put out another liter. All right, so then I actually transfused him 3 units of O positive blood in the ER. We put an NG tube in and put out another liter of dark blood. I gave him PCC high dose and TXA 1 gram. He was actually stabilized. He never got intubated. He never lost consciousness or coded. The next day, they took him to the endoscopy suite. They found a LA grade B reflux esophagitis and Mallory-Weiss tear. He had a non-bleeding gastric ulcer. He had non-bleeding gastric ulcers with no stigmata of bleeding. It was biopsy to rule out malignancy. There was 1 large non-bleeding duodenal ulcer with pigmented material. It was biopsy to rule out malignancy. Endoscopists thought this was likely the bleeding source. So then he had palliative care consult, was placed on inpatient hospice, and then he died about a week after he presented to me.
So that's one thing I was going to bring up. I think that it's super hard in these situations, and sometimes it's not possible. But when these critical patients present with a history of like malignancy or some other end-stage type disease, to make sure that their wishes were to be resuscitated. And sometimes that's we get deep into the resuscitation and find out that that's not what they want. That's not what they wanted, and more of a comfort care type thing. But yeah, I learned to respect these patients at Maricopa, and you see these are kind of the talk and die in that population where they come in talking to you, maybe just have a little fleck of blood on their shirt, and they tell you they've been vomiting blood, and then suddenly things decompensate very quickly. I remember I had a nurse in the jail unit at Maricopa. That was standing at the foot of the bed of a young man, probably in his late 20s, who projectile vomited like 1.5 liters of blood straight at her, and just looked like someone dumped a bucket of blood on her. And it was just everybody's just in shock, and it can happen quickly for sure.
Yeah, these are harrowing scenes, and these are sometimes it's really unexpected. It just happens to you, and then you have to think quickly, and hopefully going through these studies, going through teaching you how to think about things conceptually, help you make a decision quickly in these critical patients that can really die literally in front of you, right? So this patient, fortunately, worked out very well with, and we don't know, I don't know if TXA helped or not helped. I think that, yeah, we have to respect the patient's decision for their advance directive. Now, with this gentleman, daughter was at the bedside, so they wanted everything done, of course, and so we went ahead and just resuscitated him. Anything else to offer, Dr. Domer?
Yeah, just these are great patients to teach our nurses, especially our younger nurses.
Yeah.
Because they may look at you and say, "Whoa, why are you doing all this?" And just kind of helping them understand the critical nature. And many times you have this sort of calm before the storm where they don't look that bad. And just having that following that gestalt that you talk about and doing things sooner rather than waiting for things to crash is the way I like to go on these folks.
Yeah, honestly, as emergency physicians, we really, really have to plan for the worst and hope for the best. I mean, you might have heard this analogy before, but I've said this and heard this from predecessors, but if you emergency physician, when you hear hoofs running behind you, we're thinking a rhinoceros is charging at us. It may not be, but we're thinking a rhinoceros is charging, so get out of the way, right? So,
right. Yeah.
Well, thanks everybody for coming back this month. I so much appreciate your support. I really hope that you are able to learn something from my labor of love. So, Paul, thank you. I'm so glad I finally got you. I got all my Maricopa grad fellow alumni on my iCubed. I'm so excited about that. So thank you so much for spending your time with me today.
Thank you. I'm honored to have been invited on. Thank you very much.
Oh, you're quite welcome. All right, so this is probably January of 2021 when you see this posted. Please remain vigilant and be careful. Your community really needs you. Wear your PPE, okay? So we'll see you next month. Bye. Bye, Paul.
Bye.